Alright, shifting gears a little bit from elbow to wrist and hand and finger. This is out of chapters 22 and 24 out of your text. We'll take a quick peek back at wrist and hand anatomy just to kind of refresh, and then take a look at some specific injuries that we could rehabilitate, and then some general rehab concepts and techniques. Alright, so several that we're going to take a look at here. Many of them are chronic overuse type conditions. Some of them are acute, but we'll just take a look at these as we go. Alright, so if we're dealing with a distal radius fracture, these can be simple fractures that involve the growth plate, may or may not involve the growth plate. Our kind of simpler ones are going to be non-displaced. They usually will heal on their own. Just simply be casted, no big deal. More involved fractures that involve the articular surfaces, or if there's fragmentation of the bone itself, then these can be more problematic and may be surgical cases. Okay, now the question here becomes, if there is growth plate involvement, is there a disruption of the normal length of the radius? And in the case of a distal ulna fracture, the length of the ulna. Okay, so if there is growth plate concerns in a skeletally immature patient, then that will have to be addressed before we initiate any type of rehab. So usually that distal radius fracture is going to occur as a result of a FOOSH. Critical that these get reduced and immobilized as soon as possible so that we don't end up with a non-union. Even if we are casted and mobilized, we can still utilize isometrics to try to maintain the nerve pathway. Now, with the distal radius fracture, another potential complication involves the carpal tunnel. So if they've got neurologic symptoms out into their hand, then we may also have to treat this much like a carpal tunnel case would be in the case of carpal tunnel syndrome. Okay, there's also the possibility here of tendon rupture, in particular the EPL, just due to its proximity to the distal radius. Okay, so our progression here will include what we see depicted here are tendon gliding exercises, where we will do digital flexion and extension, trying to work through the entire range, just ensuring that those tendons don't adhere to any of the healing structures deep to them. Wrist range of motion exercises would begin as soon after we come out of that immobilizer as possible. And then we can also work with putty exercises for a couple of weeks following immobilization. Okay. So here we see some examples of some passive stretches. So just holding it in that supinated position may be a stretch sensation, and then further pushing them beyond overpressure type stretching. Okay. Active motion, remember to focus on wrist, not just finger motion. Once they've come out of that immobilization, whether it's a cast or a splint, whatever, we need to restore that wrist function as soon as possible. Okay. Also notice the force for pronation and supination is being applied to the distal radius and ulna, not out at the hand. We're not necessarily trying to torque the carpal bones or the carpal structures. We're trying to get that mobilization through the radius and ulna. Some other things we might want to do: load bearing in the upper extremity, using the Swiss ball. We can do this off the end of a table. Working closed kinetic chain exercises into this. Lots of times we think about functional exercises as being open chain in the upper extremity and closed chain in the lower, but load bearing through this distal radius fracture is actually going to be beneficial at the proper time, because we know from Wolff's law that force transmitted through that healing bone is actually going to be beneficial for remodeling. Okay, so lightweight TheraBand tubing, closed chain exercises, modifications of push-ups and planks are going to be good here. Just keeping in mind, if we get to end range extension like you see in the patient here, early on that may actually exacerbate carpal tunnel symptoms. So we have to be cautious here. Okay, our criteria for return: if it's a non-displaced fracture, they may actually be able to return 2 or 3 weeks post-injury with a cast. In some sports, that's going to be problematic. We couldn't return to play in basketball with a cast, but in football, with a properly padded cast, they can return. If they've had an open reduction internal fixation, they may be able to return 3 weeks plus post-injury, and then no protection at all, somewhere around the 6-week range. If it was displaced, they're probably going to be out for 6 weeks, potentially longer, just depending on the severity of the injury. And it is going to depend very heavily on what they do, whether it's their dominant hand, the nature of the sport. Okay, with wrist sprain, this oftentimes is going to be our diagnosis, even if it's something more severe, at least initially. A TFCC injury, a scaphoid fracture. Lots of times these will present as kind of this diffuse submaximal. It hurts, but it's not really off the charts kind of pain, non-specific. So we just kind of write it off as a wrist sprain. So generally speaking, anytime I diagnose a wrist sprain, then I'm cautious, and I definitely want to continue to monitor them to make sure it's not something more than that perhaps I've missed, like a TFCC. That's almost always going to be a surgery. Typically the mechanisms are going to be the same, so that's really of no help clinically in diagnosing that Fuchs injury, or engaged with an opponent, or in the play with some sort of twisting or torque involved. Some also involve impact, striking a golf ball fat, striking the ground with the club, or direct impact with an opponent. Okay, so our rehab concerns here are to rule out a more serious injury, monitor their pain, their swelling, their range, and their strength as we go. Sometimes it may be beneficial to immobilize them for their ADLs, so putting them in a cock-up splint may be beneficial for rehab. We pull them out of the splint for rehab, but when they go to class or when they're going to work, they're using some form of immobilization. Once we get a decrease in pain and swelling, then we want to restore their range and restore their strength as quickly as we can. And their rehab progression is going to be very similar to what we talked about just a second ago with their distal radius fracture. Criteria for return for our wrist sprain: whenever they're comfortable. Usually they're going to want to be taped or braced, at least for a while, until they've fully recovered. Now, we said a lot of times TFCC can present much like a case involving a wrist sprain. So our TFCC is a stabilizer of the radial ulnar joint, and anytime I've got medially centered wrist pain, whether they can recall a mechanism of injury or not, I'm highly suspicious that there's TFCC involvement. Usually this is going to occur as a result of an acute injury, okay, and oftentimes these injuries are going to be degenerative in nature. They're not going to heal on their own, okay. So with these, I want to be cautious to get that proper diagnosis. We're going to need a full eval to make sure there isn't anything else going on, and due to the relatively poor blood supply to the TFCC, this is almost always going to be a surgical case. Okay, they're going to be mobilized and in a post-surgical dressing for up to 2 weeks, and then we're going to start flexion and extension exercises at 4 weeks, not working on pronation, supination, or ulnar and radial deviation until later in the progression. Okay, so generally 2 months the splint gets removed. They'll start passive range of motion about this time. We said we could do flexion extension. That's the extent of it. We're not going to get aggressive with anything that involves load to the TFCC until round about month 2. Okay, criteria for return here. In this example, this would be a hockey player. Okay, they could do stick work. In the case of a baseball, softball player, they can start swinging the bat at 10 weeks, something like that. But we're looking at 3 months before full return to play. So this could potentially be a season ender, depending on where they are in the season. Now on the radial side, so TFCC we always think ulnar side. On the radial side, our concern with our wrist sprain is scaphoid fracture. And so we've talked about navicular scaphoid fractures before, and the concern here is that that scaphoid has a relatively poor blood supply and it will turn into a non-union relatively easily if this goes undiagnosed. So pain in the snuff box, mechanism of injury consistent with a sprain, I'm going to go ahead and treat that like it's a scaphoid until I'm told otherwise. Okay, so they're going to be immobilized. This may or may not involve a surgery where the scaphoid is pinned back together. If it's non-displaced, we can sometimes manage this non-surgically if we catch it early. If we don't catch it early, then we're almost always looking at a surgery. So after immobilization, range of motion work focusing on the wrist would begin. Thumb range of motions exercises would start after they come out of that. Strengthening exercises would begin after that. You know, these will usually recover pretty predictably, but the problem is during that time of immobilization, they're probably not going to be able to do a whole lot, whether that's in their sport or for you in rehab. Okay, so criteria for return here for a scaphoid fracture is going to depend on the sport. They may be able to play in a cast as long as they're padded. They can play with protection until that bone is fully healed. They may need to continue to wear some sort of splint or padded tape job in order to return before they're completely healed. Okay, lunate dislocation, we see that here. The lunate is considered the keystone of the carpus, so if we've got instability in the lunate, then essentially the entire wrist is unstable. Usually this thing is going to dislocate palmarly with a significant loss of ligamentous stability. If we think about what traverses palmarly, then we start to see that nerve issues, similar to what we have with carpal tunnel, would also be a problem here. So median nerve compression is often associated with this injury. So lots of times if they've got a dislocating lunate, then it's going to have to be pinned back together, potentially even a carpal fusion of some sort. So in this example we see a normal carpus. This is actually a chevron shaped carpus like we'd see in a Madelung's deformity. So this is usually congenital. This can also be acquired. This was a gymnast that I worked with. She was a vaulter and a tumbler, and so what happens here is centrally the growth plates are kind of slammed shut. Peripherally, so it's not really medial, it's medial on the radius and lateral on the ulna. They're not closed prematurely, so our carpus ends up kind of growing in this V shape. And what happens here is the lunate ordinarily comes to rest right on the radius, so it's got a nice load bear through this central column. Okay, capitate there to bear load. But in the case of a Madelung deformity, the lunate is not, it's kind of hung out to dry there, and if anything, all it does is wedge the radius and ulna further apart. Okay, so in a case of a Madelung's deformity, this may be a surgical reconstruction. If it were a patient that had a more normal wrist architecture, then we might be able to manage this conservatively. Okay, so whether or not they need surgery is our first question. Without surgery, they may end up with pain, weakness, clicking, periodic dislocation that just occurs at it's never going to be a good time. The carpal tunnel may also be involved. We may have to treat it. Weakness associated with grip strength that compromises performance may be an issue. We have to maintain range of motion in joints away from the lunate, so wrist and elbow, fingers, all those concerned, we would want to maintain range of motion. Okay, our rehab progression is going to be very similar to distal radius fracture. A lot of our gripping, pinching type exercises, extension type exercises. Once we get them out of the cast, active range of motion would begin, and we'll progress to passive stretching and general strengthening as they progress through. In order to return to play, we would probably have them taped or braced, and in the case of my athlete, she wore a leather palm guard called a lion paw, and she wore that for the rest of her career basically. We need to see good range of motion, good strength, good function, and something like a palm or tape job may be beneficial. Alright, that leads us to hamate fractures. These can be, I've seen these in baseball players diving headfirst into a bag. Golfers, I've seen this happen. They strike fat and the club handle actually rests right over that hamate. So due to its prominence, its bony anterior prominence, as well as what attaches to it, if we've got a fracture to the hamate, it's almost impossible to immobilize it, so this is almost always going to lead to a surgery as well. There's also, again, underlying neural structures that may exacerbate the condition. We may have a lot more symptoms because of it. So we get a shearing force transmitted from the handle of the club, strike an unexpected object. See this in a foosh from time to time. You'll also see it in kind of a self-defense mechanism. It can also be a result of a stress fracture where it's sort of weakened over time. Now there have been some efforts to try to minimize the amount of compression. So for example, an axe handle bat, there's actually an aluminum bat company out now for the longest time. This this modified handle design has been out in wooden bats, but within the past few years it's also come out in aluminum bats. And so what you see here is this angled knob actually prevents that knob from resting right over the hamate. So if you've had an individual who's in a stick and ball sport like this and they've had a hamate fracture, then one of these modifications may be beneficial. The alternative is to use a normal bat, either choke up or put them in a special batting glove that has additional padding over it, or even tape over it. Chances of healing conservatively pretty minimal, so this is almost always going to be a surgical repair, and then following excision of that fragment, scar massage, grip strength, they're going to be tender and hypersensitive, or they, kind of two ends here, either tender and hypersensitive, or they may have, sorry, my camera's moving there, they may have paresthesia over that area. So either way, it's going to be problematic for them. So scar massage can ensure that we don't get adhesions to the deeper structures, and then padding and protecting that is going to be important for us as they progress. Alright, carpal tunnel, what you see here, we see this atrophy in the thenar eminence. You also see it here. That median nerve gets compressed. Oftentimes, we know that carpal tunnel, there are 9 tendons that traverse through there, and the median nerve, and they are confined in space. Okay, the roof of the carpal tunnel is the transverse carpal ligament. The arches are formed by the bones of the carpus, so there's really nowhere for it to go if things get irritated. Okay, so we get kind of this inward swelling, and kind of like we talked about with compartment syndrome in the lower leg, if there's nowhere for that swelling to go outward, it moves inward and we get compression of neurovascular structures. So in the case of carpal tunnel, that median nerve gets compressed. Over time we lose tone in the thenar eminence. We start to lose grip strength. We get numbness and tingling on the sensory side. So there's really kind of two ways we can approach this. We can eliminate what caused it and hope the symptoms go away. In the case of the industrial setting where I worked, that meant basically quitting your job. You either used your hands and you had a job, or you didn't use your hands and you didn't have a job. So the alternative was a transverse carpal release, where they would actually cut that transverse carpal ligament out. You see the surgical incision here. These patients will have, more often than not, they'll have kind of a numb or a dead spot through the palm, some tenderness once they heal from the surgery, and they don't like vibration. They still have trouble with grip strength, even months and years post-surgically. You combine some of their behavioral issues, behavioral factors with this. Their diet wasn't always ideal. Many times they were smokers, so the risk of incidents goes up pretty substantially if they are nicotine users. Okay. This can result from acute trauma as well, but more often than not, this is an overuse condition. So in office workers, we see it from spending time on a keyboard. In an industrial setting, we see, in my case, it was at a tire plant where the individuals were constantly manipulating basically rubber sheets, sheets of rubber used to make truck tires. So our rehab concerns here will usually start conservatively. In the place I worked, we would try to attack carpal tunnel for upwards of 6 months before surgery was even an option. In an athletic world, that would never happen. If we tried conservatively and it didn't work after a couple of weeks, then we'd look at surgical options right away. But in the industrial setting, a couple of things. First of all, they want to avoid the cost of the surgery. Second of all, they want to avoid potential fines from Occupational Health and Safety Administration, OSHA, if their incident rate of carpal tunnel claims goes substantially higher, then that company could be fined for basically operating an unsafe workplace. Okay, so rest. So in the industrial setting, there were some light duty positions. So an individual would come to us for therapy. They'd be moved temporarily from their normal job into into the shipping office or into more of an office type situation where they didn't have to use their hands quite so much, and modifying tasks. Splinting, particularly night splints, what oftentimes can happen as we sleep, our wrist drops into either end range flexion or extension. In the case of flexion, we sleep in that flexed position. We're putting compression on the median nerve. In the case of sleeping in extension, we're putting tension across it. Either way, it's not ideal. So putting them in a night splint, a cock-up splint that holds them in neutral for the 7 or 8 hours can be very beneficial. After they've had the release, we need to do scar massage over that surgical incision site, tendon gliding exercises, not just wrist and hand flexion and extension, but systematic individual tendon flexion and extension exercises to minimize the risk of adhesions there. With our rehab, we would do gripping exercises. We don't want anything that involves tension through the palm where that incision is. So that's why I say avoid symptom aggravation. It might be tempting to do some dumbbell flexion and extension wrist exercises, but if holding the implement causes compression to the carpal tunnel, then we're going to be probably making things worse rather than better. We'll introduce these 2 to 4 weeks post-surgery, and we want to maintain upper body conditioning. Okay, for return to play here, they can play with this. This isn't necessarily something that's going to prohibit them from participating, but we may need to modify what they're doing in order for them to continue to perform well. So in the case of a hitter, if they lose grip strength, then they're not going to be able to hold the bat as well. They may have trouble holding the ball to throw it. So there may be some evidence of this going on, even though it's not something that would be an absolute contraindication to participation. Usually after surgery, when we've removed the sutures, they're usually free to return as long as we cover that wound and deal with that surgical incision appropriately. So that's it on carpal tunnel. Alright, moving on to Boxer's fracture. Here we've got a fracture to the 5th metacarpal neck. Oftentimes perfect anatomic reduction isn't necessary. There may be a high level of mobility here. We may get some rotation that occurs from this. Call a Boxer's fracture due to a blow to an immovable object usually. They may have a mass in the palm or kind of a clawing presentation. Usually this is going to occur as a result of striking something with a closed fist. With our rehab concerns, first question is skin integrity. Was it open? Was it closed? If it was closed, then we don't necessarily have to worry about it. Proper immobilization might include making a splint out of orthoplast to ensure that that fifth metacarpal is appropriately immobilized. If they've had an open reduction internal fixation, they can start active motion at the fingers within a couple of days after the procedure. There are some options that we can use. So in this case, they've been splinted in flexion. In this case, the wrist has been immobilized. In this case, neither. We've just immobilized just that fifth ray. Okay, so we want to make sure that any uninvolved joints are maintained during that splinting, and then after a month of splinting we can start metacarpal phalangeal range of motion. Then somewhere post the first month we can start some general resistance training with increased intensity by the 6th week. As far as return to play, stable, no clicking, no popping, none of those sensations that we have similar to a fracture, no pain with movement. Usually they'll play for the first few weeks with some sort of protection, and it depends on the sport whether or not they could return or not. So if we've got a basketball player, something like this would be out, but for a football player with padding we could do that. Okay, Dequer veins, here we get this stenosing tenosynovitis. They'll have inflammation in that first dorsal compartment. Could be the APL or the EPB. The more wrist motion they have, usually the worse these get. These are usually triggered by overuse. May have poor mechanics, poor posture. In the case of racket sports, we've already kind of talked about at the elbow. Kind of the same thing holds true here. Repeated wrist radial and ulnar deviation can trigger this, and every once in a while this can be the result of a direct blow. So we want to rule out a fracture, and keep in mind if we're right over that snuff box of the wrist, so we want to make sure we're not missing a scaphoid fracture here. We also want to look at mechanics to see what triggered this. Treat their pain, treat their swelling, remove any activities that might potentially be aggravating. We will utilize things like static stretching, extension of wrist, also some load-bearing activities over time, maybe even plyo, light plyo on the ball, wall ball, that kind of thing. For return to play, pain and strength are going to be our limiting factors. So as long as they can tolerate it, then they can probably be okay to return. We want pain-free range of motion, good strength. They can return even if they're not 100% pain-free. If they have a surgical release, this may be as quick as 10 days, 2 weeks before they return to play here. This tends to be one that is self-limiting. Okay, they'll usually remove themselves from participation before it gets too severe. Okay, with a gamekeeper's thumb, stretching or tearing an ulnar collateral ligament, a complete rupture will require surgery. If it's less severe than that, these can oftentimes scar down and be okay depending on the sport. Depends on how much angulation, how much opening they have as to whether or not this is going to be addressed surgically or not. One potential complication here is a Stenner's lesion. This is when the distal edge of that collateral ligament displaces. So you see that illustrated here. That ruptured end is no longer in contact, therefore it's not going to heal. Okay, this requires quite a lot of radial deviation, up to 60 degrees. So generally, a patient with a suspected Stenner's lesion, they're going to have quite a lot of pain on that web space side, open up pretty substantially, and if there's not a positive response to our conservative management, even initially, then that's when we may want to consider the possibility that it's more than just a simple gamekeepers. Okay, so our injury mechanism here will usually be a torsional load applied to the thumb. We'll see this skiing, ski pole sticks in the surface. Could be forced abduction or a fall on an outstretched hand. We want to make sure we get this diagnosis as early as possible. We want to avoid any instances where we've got chronic instability, weakness, arthritis type symptoms. Generally, we're going to immobilize the more minor gamekeepers' injuries and usually just manage those conservatively. Cross-fiber friction massage, Graston, Sastum technique can be beneficial here. But if they do undergo surgery, then we want to avoid radial stresses on the thumb. So we have to be cautious about what we have them grip or hold so that we're not getting loading there. This condition includes, may also involve other uninvolved joints as well. So we have to be cautious here and ensure that we don't just focus so much on the thumb that we end up neglecting the other body parts. Okay, so our rehab progression here would be 5 to 6 weeks of protective splinting. We start our active range of motion exercises, flexion and extension after that. Our putty exercises can begin. We want to be cautious about anything that involves excessive squeezing that's going to load that thumb up. The length of time for return to play really just depends on the sport. Okay, so there are a lot of taping and splinting options. A thumb spike a tape job or a thumb spike a splint may be beneficial here. Pain should be reduced, and so in other words, they don't have to be 100% pain free, but they should be able to do whatever it is they need to do without significant limitation due to pain. If they do end up having surgery, they're going to be out a minimum of 2 weeks, potentially much longer depending on the sport. Okay, in the case of a finger joint dislocation, really depends on the digit and the direction of the dislocation. These are going to be reduced, obviously prior to rehab, but the question becomes, how unstable is that moving forward? Lots of times if we've got a PIP volar dislocation, these are rare, they won't reduce easily. There's usually a fracture associated with that. You can kind of see that here. Prior to reduction, we want x-rays on this. In the case of a normal volar dislocation, we've got a hyperextension force or a compressive load. So what you see here, this has been taped with simple compression bandage to help with swelling. We just want to rule out a fracture first. From that point, it really just becomes more about restoring and maintaining range of motion than anything. Okay, so a simple dorsal metacarpal phalangeal dislocation, they're going to be splinted at 50 degrees of flexion for about a week. We'll start active range of motion after that. So I know we've talked police until you're blue in the face, but in this instance, they're immobilized for healing's sake. There's nothing we can do in terms of range of motion for that until that immobilization is removed. Okay, and then we're going to progress from that into increased range, into strengthening exercises. So our putty squeezes, our digital grippers, all those kinds of things will be beneficial here. We can also use buddy taping. We can use other types of external supports for these. If they've had surgery, then scar massage is going to be beneficial. We'll go over kind of how to do that in lab just to minimize scar tissue adhesions. If they end up with significant scarring, then they may need to be referred because that can impede their range of motion. There can be a soft tissue component to that loss of pliability. Okay, so here we see an example of putty squeezes. We're going to treat open or irreducible fractures. They're going to require wound management. So like we said, in the fingers, soft tissue adhesions, scar tissue adhesions can definitely impact range of motion. So we're probably more aware of those than anywhere else in the body. So we actually have to treat the skin, not just the underlying pathology. Okay, criteria for return, really this is kind of a wild card. It's hard to say. So if you've got an athlete who dislocates their finger, they might be able to return the next series. They might be out for several weeks. There's just really no way to realistically predict this ahead of time. In the case of MCP, they can be reduced and return almost immediately. Okay, if they've had surgery, they're probably going to be out for a couple of weeks. They got to recover from the surgery and make sure that their wounds are healed. In the case of a PIP dislocation, they too can return almost immediately if they've been if they've had more symptoms. Then that may delay their return and decrease their effectiveness. Okay. In the case of a DIP dislocation, kind of that same idea there. 10 days minimum following suture removal. So we're still kind of in that 2 to 3 week range. Jersey finger, pathomechanics here. The patient is trying to flex. Their fingers are being pulled out eccentrically, so we end up with an avulsion, and really the severity depends on how much that tendon retracts once it is avulsed. Okay, this one is pretty severe. Okay, surgical intervention, we're looking at 3 months of rehab and recovery. This is certainly one where it's going to seem like just a finger, but it's going to drag on. The rehab for this one can seem to take quite a while. So we see this mechanism here. Our concerns here: good tendon glide. If they've had surgery, again, that soft tissue, scar tissue adhesion can be particularly problematic. Proper patient education and instruction here is critical. We can't rush this one. Okay, so if I had surgery, after 2 to 5 days, remove the dressing, apply a splint. First 3 weeks, you notice mostly just range of motion exercises. When we get to week 3, we can start doing some fist exercises. Okay, when we get to week 6 through week 8, can start using the hand for ADLs. Got to be careful here not to overdo it, because the repaired insertion is still very vulnerable. Okay, 8 to 10 weeks, dynamic splinting can be initiated. We don't use a lot of dynamic splinting in athletics. It wouldn't be something they played with, but it could be something that they use, while they're doing ADL type stuff. When we get to weeks 10 through 12, we start full strengthening, and then at week 12 we want good tendon glide, full strength, full return to activity. Now, for our criteria for return here, depends on the sport, the position played. We want to make sure we take in consideration the surgeon's input. They can generally play without protection, usually by 3 months post-op. Be careful here. Avoid that early return due to the chance of re-injury. Some protective taping may also be necessary for early protection as they're making their way back to full return. Mallet finger, kind of the same idea here as jersey finger, just we're looking at the extensor side rather than a flexor side. This may involve an avulsion. It may just be a tendinous injury. Okay, this may require an open reduction internal fixation depending on the severity. Usually this is going to be forced distal interphalangeal joint flexion while they're held in extension. Sometimes we'll see this. They catch a ball off the tip of the finger and it's forced into flexion even though they're trying to extend it, and that's where we get the injury. Not a lot of concerns here. Splinting and immobilization will follow immediately, upwards of 2 months. After 2 months of splinting, we can start range of motion exercises. Okay, so putting them in that extension splint is going to be important. For return, the athlete needs to be, they can be allowed to return if they've been splinted appropriately. If they're unable to participate due to the rules, we'll see this in basketball, we'll see this in some of our other hand-to-hand sports, then there's really nothing we can do about it. Their injury isn't preventing them from returning to play. It's the rules protecting other athletes that's preventing them from return to play. They can probably still practice. There's probably lots they can do in controlled environments, but there's not a whole lot they can do to skirt the rules. They've got to be splinted. Okay. In the case of a boutonniere deformity, we see this kind of characteristic kind of button hook look to the finger. Here we see the PIP is in flexion and the DIP is in extension because the avulsion has occurred at the central slip at the PIP joint. Okay, when that flex deformity is present, that injury becomes very difficult to treat. We want to catch this early. We don't want them to play with this because the ability to address this goes down the longer we wait. We want them splinted appropriately in full extension, and we're going to modify the way they're splinted due to changes in swelling. So we want to avoid passively allowing that PIP into flexion. After the splint's removed, it'll have a tendency to want to return to flexion, and we want to be aware that that injury will present as that PIP flexion contracture before that DIP hyperextension comes in. So here we see how we splint that boutonniere. We can continue to do gripping exercises on the non-involved fingers, wrist and hand, flexion and extension exercises, but there's nothing we can or should do to the involved digit itself. Okay, so these will slowly return, but we may be looking at 3 months here before we're able to fully return to play. Okay, they can return to activity when that finger's comfortable. The effective finger needs to be splinted in full extension. If the sport doesn't allow for splinting of the digits, then they're going to be out for the duration of time that they would be splinted. We may be able to buddy tape them, but even buddy tape still allows flexion to occur, so we don't want that. Alright, so we're going to pause there, and when we come back, we will hammer through these last few slides.